Thank you. Now we are moving on to the next keynote speech by Dr. S. Selva on the topic HIFU for fibroids and adenomyosis, a breakthrough approach that's redefining non-invasive care in gynecology. Dr. Selva is a consultant, OBGYN, and a subspecialist in reproductive medicine at the Mahkota Medical Center in Melaka, Malaysia. He's a vice president of HIFU of the International Society of Minimally Invasive and Virtual Surgery, and he also runs Malaysia's first ultrasound-based HIFU center at Mahkota Medical Center, Melaka, and provides non-invasive surgery for fibroids and adenomyosis. Over to you, sir.
Thank you. Again, let me thank Dr. J. Krishnan for inviting me and for me to speak on this topic on HIFU for fibroids and adenomyosis. Okay, this is my disclosure. I run a HIFU center at Mahkota Medical Center, Malacca. And this is the HIFU center. It's a small room with the machine, and you don't have to have any general anesthesia. It's done under sedation. Okay. Many people ask me, you're a gynecologist, you're a fertility specialist, you're a laparoscopic surgeon, why do you want to do HIFU? This is the company that makes the machine. It is in China, it's at Chongqing, China. Thank goodness it's in China, so we don't have to worry about tariffs. I was invited to go and visit this place in 2018, and this is the place where they do research and make that machine. And after that, I visited some centers in Korea where this is very popular. HIFU is very popular. And I convinced myself this is probably the future for fibroids and adenomyosis. And we got the machine in 2021. Now, this is my experience. I started in the middle of the pandemic, which is July 2021. And until I arrived here, we have done 760 cases, out of which 279 are for adenomyosis and 481 are for fibroids. Now, this is my lecture outline. I will tell you all what is HIFU, what is the difference between MRI-based HIFU and ultrasound-based HIFU, how well accepted is HIFU in the world, what is the difference between performing HIFU for fibroids and adenomyosis, how effective is HIFU for fibroids, which patients with fibroids will benefit the most from HIFU? How does HIFU benefit patients with adenomyosis? Pregnancy after HIFU for fibroids and adenomyosis, which is the area that I'm interested in. And what are the complications of HIFU? Okay, the first is, what is HIFU? Basically, HIFU, which stands for high intensity focused ultrasound, it has a transducer, and this transducer focuses the ultrasound beam into a tiny spot and increase the temperature to 65 to 100 degrees, causing necrosis of tissue at this area. So the necrosis occurs as a result of heat and cavitation, in which the cells will burst and then the tissue will die. And that's how HIFU works. Now, many of us have heard of HIFU. And the HIFU that we have heard of is something called MRI-based HIFU. And this has been around for a long, long time. It was first approved by FDA in 1998. It's called X-Blade, and approved for the use of fibroids in the year 2004. And in Europe, it is made by Philips, by Sonovil and Philips. And this HIFU that I'm talking about is, as I said, from China, Chongqing, China. These are the machines that we have. This is called the JC. This is a JC200. This is the machine that I am using. And there's a JC200C and a newer machine called JC300. There are several differences between performing HIFU with MRI compared to ultrasound. Now, we know that MRI-based HIFU has got very good anatomic resolution. There's no question about that, as opposed to ultrasound. There's also something called a temperature monitoring for MRI-based HIFU, which is not available in the ultrasound-based HIFU. However, the advantages of the transducers is that the ultrasound-based HIFU is that the transducer movement is much more for the ultrasound-based HIFU compared to the MRI-based HIFU. Also, as you can see, this is in a tunnel and this is in an open concept. the patient positioning is far better with the with the ultrasound-based HIFU than the MRI-based HIFU. There's also less noise. But what is most important is that the treatment time is low in MRI-based HIFU, and more importantly, the effectiveness of the treatment is far better in the ultrasound-based HIFU than the MRI-based HIFU. I will tell you the reason why. Treatment cost is also cheaper with the ultrasound-based HIFU compared to the MRI-based HIFU. But the most exciting thing is it can be done by gynecologists, so I can do it, as opposed to MRI-based HIFU, which can be only done by radiologists. So the difference between MRI-based HIFU and ultrasound-based HIFU is in the transducer. The MRI-based HIFU, the transducer movement is limited by the size and the hole in the gantry of the MRI, and the ultrasound-based HIFU, their movement is not limited. Actually, this transducer, which is the ultrasound-based HIFU, can move 12 centimeters up, down, and sideways. And this is a big advantage because the MRI-based HIFU use something called a phase array transducer. And this phase array transducers has got 256 small focuses, and this focus actually moves. So it is not one area, but the focus moves, and because of that, the power of the machine is not as strong as that of an ultrasound-based HIFU, which only uses one transducer, and you can concentrate the energy at a very high energy level. So because of this small focus, when you're doing an MRI-based HIFU, you have to give each area sonication, which lasts for 10 to 20 seconds, as opposed to second-by-second ablation when you use an ultrasound-based HIFU. This is very important because the uterus, if you're doing the brain, it's okay, you can fix the brain and you can wait for 20 seconds. Whereas if you're doing a uterus, the patient can move, and that will affect. So your positioning of the beam have to be more, it cannot be more nearer to the serosa or the endometrium, as opposed to ultrasound-based HIFU, where we can go very close to serosa and endometrium because we are doing it second by second. It is done under live ultrasound. So that is the difference. So we could not use the MRI-based HIFU in comparison to the ultrasound-based HIFU. MRI-based HIFU actually has failed in uterus. It is done very well in the brain, but it's completely failed in the uterus because of this reason. Because when you're doing an MRI-based HIFU, you have to sedate the patient very highly, and the patient has to be very quiet for 20 seconds, and you cannot place the focal point in an area that will be affecting the bowel, for example, when you're doing the procedure. So there's a difference between these two. Let me see. So as I said, the ultrasound by HIFU is a real-time ultrasound imaging while performing the HIFU. The transducers are larger and more powerful, better transducer movement, shorter operating time, and so we have better success rate and higher ablation rate as opposed to MRI-based HIFU. So next question is, how well accepted is the ultrasound-based HIFU in the world? Now this is the latest. This is where all the machines are. Actually, it's been in Oxford for the last 25 years, I think. But they had never moved off from research to daily usage in the United Kingdom. It is available in some countries in the Europe, and it is very popular, of course, in China. It is they call it the entry level for fibroids in China, Taiwan, Japan, and this part of the world. And they have done, so far, 318,000 cases have been performed for HIFU for different diseases, not only for fibroids, but it's also done for cancers of the pancreas and liver cancers and extra. So for benign, they have done 291,000 cases all over the world. So it is popular in the eastern region, but it's still not reached the Europe, and of course it's not reached America, and you know the reason why. So the next question is, what is the difference between performing HIFU for fibroids and for adenomyosis? Now, we know that fibroids have got a capsule. So the capsule contains the fibroid, and when we do ablation for these fibroids, we can actually ablate almost 100% of the fibroid. And this is a contrast MRI done before HIFU, and this is done after HIFU. Once you have done, it becomes black. That means the whole fibroid has been ablated. Whereas for adenomyosis, we know that it is found all over the place. So it is almost impossible for us to ablate completely an adenomyosis. So it's actually a big challenge when we are doing ablation for adenomyosis when we compare to fibroids. So the percentage of ablation will differ, as I will explain later, between different types of patient when we're doing HIFU for adenomyosis. So how effective is HIFU for fibroids? Now, these are studies that are done in China. There are many studies that has been done, and I will just highlight one simple study. This is a study that was done between 2006 and 2009 in China, 757 patients with 1,114 fibroids done in the first hospital of Chongqing Medical University. And out of these patients, these are the numbers of patients with submucous, intramural, and subserosal fibroid, and the non-perfused volume is 84.8%. It is said that if you can do 70% ablation of a fibroid, the fibroid will die. Not all, but the majority of them will die, and here we can reach 80 to 90% for fibroids. The symptom improvements are within 3 months. The patient has got very good improvement of 92.5%. And the fibroid shrinkage is 31% at 3 months, 58.5% at 6, 70.3% at 24, and 82.8% at 36 months. So the next question is, which patients with fibroids will benefit the most from HIFU? Now, in my mind, there's a lot of advantages and disadvantages, but the patients who will probably benefit the most are the perimenopausal women with fibroids and adenomyosis. And we have got a group of women who don't want hysterectomy or who don't want myomectomy. And these are the group of patients, because when we do ablation and kill the fibroids, we can bring them to menopause and the fibroids will die. So this is the whole idea. This is a very good group of patients, and I do a lot of patients in this group. Patients who are unsuitable for general anesthesia, these are also a very good group of patients. Patients with CVA, DVT. These are patients who not many doctors would want to take them up for surgery. They will send to me to do HIFU. Patients with previous myomectomies are also a group of patients, although these are very challenging patients. I frequently see patients who have been operated once, twice, and they say, I don't want to go for another operations. Can you do HIFU for me? So this is another good group of patients. This is an example of a lady with this kind of abdomen, with a midline abdomen. Nobody wanted to do surgery. She had a large submucous fibroid. And and she was bleeding, heavy bleeding. She was sent to me for HIFU, and we performed the HIFU for her. This is the contrast MRI just before HIFU, and you can see that there's good blood flow into this fibroid. And this is after HIFU. You can see that the whole fibroid has been ablated. How we know it's ablated is that the fibroid is black in color. It doesn't absorb the contrast media, and so that we know that it has been ablated. And she's doing well. So these are type of patients that usually I get sent to do HIFU. Now there's another group of patients, the patients with multiple fibroids. These are patients we know that if we do surgery, it's going to come back. And so this is an example of a patient with leiomyomatosis. We can say the whole uterus is filled with fibroids. I discussed with her, say, we want to do surgery. Yes, we can, but it was going to come back. Would you want to do HIFU? And she agreed to do HIFU, and this is how the uterus looks. So all the fibroids within the uterus has been ablated. So this is going to be a lady who is going to have some difficulty in getting pregnant because her uterus is filled with fibroid, and she's willing to take the risk, and she didn't want to go for surgery. And so this is another group of patients that will benefit from HIFU. Another group of patients which I see very often are infertility patients. And infertility patients with big fibroids will do surgery, but if they have small fibroids, say 2.5, 3 centimeters, and they're not getting pregnant, to subject these patients for surgery may sound very cruel. So this may be a good group of patients. I'm experimenting on this as well. So this is a review paper that I wrote some years ago, intramural fibroids and fertility to operate on all. These are intramural fibroids, not type 3, not type 2, not type 1, but type 4 fibroids in the myometrium. They are small, but they're still not getting pregnant. Should we go and remove them? And this may be a good group of patients that we could ablate the fibroid and the patient could get pregnant. I give you an example of this patient of mine who had multiple fibroids in the uterus. And this is the contrast MRI, and we debated, so, okay, are you a good candidate for surgery? We can do surgery, or we can do HIFU, and she agreed to do HIFU. And this is after the HIFU, and I managed to ablate majority of the fibroids. And after that, she couldn't get pregnant still, and so we did IVF, did embryo transfer, and she actually conceived and actually delivered the baby. And you can see the fibroids that are there. They have not completely resolved, but they are all dead fibroids. And the patient actually did well during the pregnancy. So this is a group of patients that I'm seeing whether they will benefit from HIFU. Okay, let's move on to the more difficult topic. How does HIFU benefit patients with adenomyosis? Now, we are all not great surgeons like Dr. Hafiz, who can do a fabulous adenomyomectomy. I am always worried to do adenomyomectomy because I'm worried that my patients will have uterine rupture after the surgery. So this may be a good group of patients that may benefit from adenomyosis, and this is an area of my interest. So this is what I told you all, that the ablation for fibroid is far easier than ablation for adenomyosis. So, but when we are doing HIFU for a patient who wants to get pregnant and who doesn't want to get pregnant, there is a difference. The difference is that in a patient who wants to get pregnant, we have to be very careful not to ablate the endometrium. And this can be quite difficult and can be quite challenging because we must give enough energy to kill the disease as much as possible, but not ablate the endometrium, so that we have the endometrium to receive the pregnancy. And it can be challenging because if you know that adenomyosis is a varied disease, it is got something called internal adenomyosis, external adenomyosis. The internal adenomyosis, however you are careful, it will come and ablate into the endometrial cavity. So when I see patients with adenomyosis, these are the group of patients I see: those who are not keen to get pregnant, and those who are keen to get pregnant. Those who are not keen to get pregnant, if they don't want a hysterectomy, then we can do a very thorough adenomyosis ablation. But for those who want to get pregnant, there are different groups. The ones who have actually done IVF and have frozen embryos, the ones who are still single, and the ones who want to do something and then try to have a spontaneous pregnancy. And then we have this group of patients who are unsure whether they want to get pregnant or not. These are the 40-year-old ladies, single, and they say, okay, I may not get pregnant. So this will be a difficult group. The group that I like the most are the ones with a frozen embryo. So these are patients who actually have done IVF and have failed, and then they send to me to see whether I can do something about the adenomyosis for them to get pregnant. And this is an example. The ablation, as I said, must be done very carefully. I usually give them GnRH for 3 months, and then I will advise the embryo transfer to be done 3 months after the HIFU, because this is the time when the uterus will be at its smallest, and it will be the good time to do the embryo transfer, even before the patient actually gets the menses. This is an example of a patient, 35-year-old lady, 5 years with no children. In 2009, she underwent an IVF with 2 frozen embryos, 1 dose of GnRH given. In 2020, she underwent another laparoscopy, another GnRH, embryo transfer. She did not conceive. And then she complained of severe dysmenorrhea and was on tranexamic acid. Her uterus was 16 weeks size. There was a large posterior adenomyosis, and this is how the adenomyosis looked like. It's a large, about 16 weeks size uterus, and this is the uterus on the transverse view. The adenomyosis was more on the left side, but it was internal adenomyosis. So I did the HIFU for her, and this is 3 months later. The ablation showed a fairly good ablation. And this is a transverse view of the ablation. And I sent her back, and this is the volume reduction. The volume was 940 centimeter cube just before HIFU. And after 6 months, the uterus became 265, reduction of 71.8%. And I sent her back to her IVF specialist, who later did a frozen embryo transfer, and then she delivered a baby. So this is the area that I'm interested in, to see how I can help patients who have adenomyosis, who failed IVF, and try to help them to conceive. The other group are actually those who are keen to conceive on their own. I have not been very successful in this group of patients. Again, the ablation has to be done very carefully and then wait for them to conceive. And this kind of patients, we always tell them that because the ablation is not done completely, it will recur. There is a very good chance that it will recur, and they may have to repeat if they don't get pregnant, or they have to do IVF. And this is the patient. So, pregnancy after HIFU for fibroids and adenomyosis. These are the number of babies that have delivered after HIFU from the company itself, 3,700 babies so far. This is my experience. Out of the patients, I have got so far 17 pregnancies, 17 patients who have delivered, out of which 10 by cesarean and 3 by normal delivery. We have got 12 babies delivered after adenomyosis, 7, and all of them are IVF babies. So lastly, what are the complications of HIFU? Now, HIFU is a relatively safe procedure, but still there can be complications. And this is a very big study, about 10,000 patients who underwent HIFU, out of which the serious complications, which are actually intestinal perforation, hernias, and acute renal failure, are only 0.6%. The others are all minor complications such as vaginal secretion, leg pain, uterine bleeding, blurred vision, skin burns, etc. So it is a relatively safe procedure, and the complication rates are probably far lesser than that, even after laparoscopic surgery for an adenomyosis and fibroids. So in conclusion, when I started laparoscopic surgery in 1994, I had to convince my patients to do laparoscopic surgery and to tell them that it's superior to open surgery. Now, patients come looking for me to do laparoscopic surgery because that has been the change from those days to now. And I think in future, when HIFU becomes more popular, patients will choose this non-invasive procedure. This is the only procedure that is completely non-invasive. It means there's no even a needle going into the abdomen, as opposed to microwave ablation, radio frequency ablation. These are, you still poke a needle into the uterus to do the procedure. And this is going to be, I think, one of the techniques that will be chosen by women in future. And of course, it's got a lot of future in adenomyosis. Thank you.
Thank you so much, Dr. Selva, for your valuable insights.